We're going to take about 5 minutes and talk about nothing but oxygenation. The topic is that important that it warrants its own discussion. So why is the topic that important? Well, the answer is oxygen is a drug that if used inappropriately will cause harm to your patients. That's not just me saying that. There's actually quite a bit of research out there demonstrating that oxygen worsens outcomes. This study is most applicable to what we do. This is an emergency department study, looks specifically at mechanically ventilated patients, and only looked at their first ABG. Looked at the PaO2 on that ABG and its correlation with mortality. What it found was the group with the highest PaO2, so a PaO2 of 140 or greater, also had the highest mortality. The group with the slightly low PaO2 had the highest survival rate. So again, this was done in the emergency department. It only looked at their oxygenation status for a very short amount of time, and it seems that exposure to high oxygen levels for even that short amount of time increased mortality rates. So what determines how much oxygen I can actually put in the lungs? Well, this is the Alveolar Air Equation, which equates the partial pressure of oxygen in the alveolus. While you don't need to remember this equation, what I want you to take away from this are that FiO2 and mean airway pressure are the main two determinants of how much oxygen I actually put into the alveolus. So what vent settings do these correlate to? Well, FiO2 is obviously the FiO2 dial. I can go from anywhere from 21% all the way up to 100%. And then mean airway pressure, the most efficient way to raise mean airway pressure is through utilization of PEEP. So what is PEEP? PEEP stands for positive end expiratory pressure. All this is raising the baseline pressure that my patient breathes at. We know that we have the same FiO2 at sea level as we do on Everest. However, it's easier to breathe at sea level and it's easier to oxygenate at sea level because the baseline pressure is higher. With PEEP, all I'm doing is raising that baseline pressure even higher. Let's take a look at this on the ventilator. So as you can see here, Dr. Atherton's breathing on the vent and there's no PEEP. As he breathes, his pressure stays right around 0, which is atmospheric pressure. You can see little bumps in this pressure as he exhales, but he's always going back down to that baseline of 0. As I set the PEEP, you can see this dotted line start to slowly creep up. That's going to be his new baseline. And then as soon as I lock that in, you can see now his baseline pressure is staying right at 5 centimeters of water. He cannot exhale below that. That gives him 5 centimeters of water of PEEP in addition to atmospheric pressure. So in addition to increasing the amount of oxygen that I actually have in the alveoli, PEEP also increases the number of alveoli that participate in gas exchange. Here I have two very angry alveoli. The one on the right is obviously angry because on inspiration he stays completely collapsed. But the one on the left is also angry because you can see when I exhale, he completely collapses down as well. You never want your alveoli completely collapsed, even when you exhale. This is atelectasis, and it prevents these alveoli from fully participating in gas exchange. As I inspire, the one on the left will open, but then when I exhale again, he collapses back down. Now when I put some PEEP on both of these alveoli, or some positive end expiratory pressure, now when I exhale, this one on the left is stented open. That PEEP keeps him from collapsing down fully. Over time, that PEEP will start to inflate these other alveoli that have stayed collapsed down. When I exhale, the PEEP will prevent them from collapsing down again. When I inhale, they inflate. I exhale, the PEEP keeps them stented open and participating in gas exchange. This mechanism increases the number of alveoli that are participating in oxygenation and will increase your oxygen levels significantly. So the question becomes, what do I set my PEEP at? You've got to have a PEEP table. Again, FiO2, use the lowest FiO2 possible to oxygenate your patient, and as you go up on FiO2, also go up on PEEP. This is straight out of the ARDSNet trial in 2000. We made this table again because we like things that can be placed on the back of a badge. If you're having difficulty remembering what PEEP levels to use, just print this off, put it on the back of your badge, and you'll always have it there as a reminder. As you go up on FiO2, you've got to go up on PEEP. So finally, to review, always keep your oxygen levels low. Use the lowest possible FiO2 to keep your SAT right around 90. And as you go up on FiO2, go up on PEEP. Follow a PEEP table, utilize PEEP to optimize oxygenation. This has been a review of oxygenation in about 5 minutes.